Hello and welcome to this INICET November 2025 Exam Analysis and recall session of surgery questions. Overall, it was a very moderate level question paper. Particularly, surgery was easy to moderate questions, most of which were discussed in our class and directly from the class notes. I have recollected maximum questions here. So almost all out of 20, almost 19 questions were directly from the class notes. I'm very sure our students have done well and expecting a very good rank this time. So to start with, the first question: which absorbable suture causes maximum tissue reaction? Okay, so the options were polypropylene, catgut, polyglactin, and PDS. So answer is obvious since they have mentioned it as a absorbable suture. So polypropylene is ruled out. Okay, so polyglactin is a absorbable suture, but it doesn't cause that much of tissue reaction. PDS is also delayed absorbable suture, that also does, it's a monofilament as well, so it doesn't cause that much of tissue reaction. The catgut, the naturally available absorbable suture, causes maximum tissue reaction. Okay, so also chances of infections are also high with this. So because of this high reaction, this gets degraded at the earliest, say 7 to 10 days. Okay, so this is the right answer. Catgut causes maximum tissue reaction and gets degraded earlier. So this is a very favorite topic of INICET. There will be one question on this suture materials, and invariably ask this classification of suture materials, one question. So that was it. And the second question on breast carcinoma, inflammatory breast carcinoma management, they had asked. They had given a case scenario telling that inflammatory carcinoma involving most of the breast, all those things. It doesn't matter. When there is a diagnosis of inflammatory breast carcinoma, the management remains the same. It's a T4 lesion, right? T4D. So for any locally advanced breast carcinoma, always try to downstage the disease first, and then you can go for the definitive surgery. So always downstage the tumor by giving neoadjuvant chemotherapy. So that's the options, either one or two. Okay, MRM then chemo is ruled out. Okay, that's only for early this malignancies. Palliative, this is not a metastatic, so this is also ruled out. This is also ruled out. Among 1 and 2, they have asked neoadjuvant chemo, then MRM, neoadjuvant chemo, then BCT. BCT we do only for early malignancies, not the locally advanced one. Okay, so BCT also not option. We always go with MRM, modified radical mastectomy. So option A, neoadjuvant chemotherapy followed by MRM. Then you can follow it up with the adjuvant chemotherapy, or depending on the hormone status, hormonal therapy, radiation therapy, other adjuvant treatments. So option is very straightforward here. The neoadjuvant chemotherapy to downstage the disease and then go ahead with the surgery. Okay, hope there is no confusion in that. The next question, we had discussed this in class, TIGAR-O classification for the etiology of pancreatitis. It's not acute, it's not alcoholic, it's not obstructive, but it is for chronic pancreatitis. Chronic pancreatitis etiologies can be classified into T for toxins, I for idiopathic or immunological, okay, G for genetic, O for obstructive causes, R for recurrent and severe, okay, TGAR, THGAR, it would be A for autoimmune, okay, and O for obstructive, A for autoimmune, okay, O for obstructive causes. These are the common causes for chronic pancreatitis that's classified under a name TIGAR-O. Okay, so that's the answer there. So the next question, steps of laparoscopic cholecystectomy. This also we have discussed in the class. The first step is very obvious. It always starts with the skin incision, or in case of laparoscopic any surgeries, it starts with pneumoperitoneum, creating a pneumoperitoneum. Okay, so you put a Veris needle and create a pneumoperitoneum with the CO2. So that's the first step. Then in any cholecystectomy, the most important thing is the dissection of the Callet's triangle. Dissection of the Callet's triangle, you know the boundaries of the Callet's triangle. Okay, so we dissect that and achieve a critical view of safety. Critical view of safety means at the end of the dissection of the Callet's triangle, we should be able to see only two tubular structures. One is cystic artery and one is cystic duct. Okay, it's called critical view of safety. You should not be able to see the CBD. No, that much of extensive dissection also not required. Okay, so the first step is pneumoperitoneum. The second is dissection of Callet's triangle. Once we identify this critical view of safety, that two structures, then we clip them. The first is artery followed by the cystic duct. Okay, because if you cut the duct first, then there are if you inadvertently pull the gallbladder and all, there is chance of artery getting lacerated. So first always the artery with a firm grip on the cystic duct, and then clip and cut the cystic duct. Okay, once that's done, then the gallbladder is hanging on the liver bed, then it can be removed from the liver bed. Okay, so in this order only the cholecystectomy is done. 1, 2, 3, 4. So any option suggesting that is the option A. Okay, sorry, not option A, it's option B. Sorry, option B telling that A, B, C, D. A, B, C, D. Okay, hope you got it. Next thing is very factual question, that is radiation induced thyroid cancer. We have multiple times we have revised this through different practice questions and MCQs, and in our GTs also. Radiation induced thyroid cancer is a pretty easy question. It's papillary thyroid cancer. Papillary. Okay, papillary thyroid cancer. Okay, in a long standing MNG and all, it can cause follicular, anaplastic and medullary. It's associated with usually men syndrome. Okay, so any radiation induced is always papillary. There was a RTA. Which patient will you attend first? So this is the concept of triage, right? In trauma we have discussed triage. What is the color coding? Red, yellow, green and black, RYGB we remember as. Red is the immediately life threatening, yellow is not dangerous but not immediately life threatening, G is walking injured, and there's a green, and B is black, moribund patients. Okay, this is the color coding. So in this they have given you the scenarios of 4 different patients whom you are going to attend first. Means what is the priority in the triage? So a 65-year-old conscious patient with blood soaked trousers, patient is stable, so almost it's green, you can classify into green, so it's not the priority. 6-year-old girl crying constantly, so crying means airway, breathing, everything is fine, but is crying, that's not a priority. Okay, so you can give it a G only for this. 40-year-old man unconscious with noisy breathing. Okay, patient is unconscious, okay, and having noisy breathing like a stridor or grunting. Okay, so that means that airway is compromised. Patient is unconscious, upon that patient is having a noisy breathing, then his airway is compromised. So that is the priority, my dear friends. Always airway is the priority. Airway is the utmost priority. Within seconds patient can die. Okay, so this is the right answer. And we still see the 22-year-old female conscious with increased respiratory rate. That means that airway is okay, but breathing there's a problem. So it comes second. That comes second. Okay, so after for this C, then comes the D. So C is the utmost priority. Once you assess the airway, okay, remember always the second priority is not securing the airway. Before that you have to stabilize the cervical spine. Then only secure the airway, whatever with the definitive airway or adjunct airway, whatever. Okay, so this is the sequence. First assess the airway, and then immediately if there is a problem with the airway, immediately inline stabilization of the cervical spine or protection, then go for the management of the airway. Once it's done, then B, breathing, then circulation, D and E. Okay, hope this question will be invariably asked to check your knowledge on ATLS protocol. So there we go. So hope you got this concept. The next question on hernia. There are so many named hernias are there. Named hernias. So sometimes it's confusing as well. So this time they had given image-based question showing appendix in the sac. See, is a tubular structure with a mesoappendix here. Okay. So it's appendix inside the sac, so as a hernia content, what it's called. Okay, so options were Amiant's hernia, Gibbon's hernia, Greenfeld's, and Litter's hernia. Litter's hernia, we know when Meckel's diverticulum as the content, we call Litter's. Lichter's is different. Lichter's is different. Litter's is different. Lichter's is circumference of bowel. And the circumference of bowel is the content. Then it's a Lichter's. C for circumference of bowel. Litter's is Meckel. TT. Meckel. Sorry. L for L. Sorry, not TT. Sorry. L for L. Litter for Meckel. Like that. I used to remember. L for L. Okay. C for C. Richter's circumference of bowel. Greenfeld is the lumbar hernia. Gibbon's is hernia with hydrocele. Whereas Amiant's hernia is appendix as content. Okay, so Amiant's hernia is the right answer here. So there are so many, there are 20, 25 named hernias are there. We should know. Okay, this the list. Okay, next they have asked a question on bariatric surgery question. So they had asked given a image of which surgery is this. So as per my students recall, it is Roux-en-Y gastrojejunostomy. As I have put a representative image here, you can see gastrojejunostomy being done, and there is a Roux limb is also there, Roux limb, and there is a long common channel is there. If it is a short common channel, it would have been BPD, okay, biliopancreatic bypass, but here it's a long common channel and Roux-en-Y gastrojejunostomy has done. Okay, so answer was pretty obvious there, and whatever the question, irrespective of the question, looking at the image only, just by looking at the image, we have discussed this, all the three types majorly in the bariatric surgery you have. One is restrictive types, one is malabsorptive type, and the third variety is mixed types of surgeries. Okay, so this is mixed type, Roux-en-Y gastrojejunostomy, both restrictive as well as malabsorptive type. Okay. Next question, a patient underwent an inguinal hernioplasty. Arrange the steps in the order. So they have checked your knowledge on operative surgeries as well. 2 questions this time. So always the first step should be the skin incision. So that comes the first. Okay, then can't be the close the wound or mesh replacement. Before that, we have to dissect the cord structures and the sac, everything. So open the sac and reduce the content will be the second one. After that, we hernioplasty. We keep a prosthetic synthetic mesh there, and then we close the wound. So this will be the order. So 2 1 4 3. So this is the right answer. Okay, I think this is a very common sense based question. Even if you didn't know, also just by looking at the options, you could have answered it, right? Next question, a bit difficult, but if you really read it, the word meaning makes a slight difference here. Just see, a patient was brought to the casualty with abdominal pain. Which of these statements are correct? Okay, so first option was tenderness at McBurney's point is classical of acute appendicitis. Yes, if they are given it as classical of appendicitis, that's correct. Tenderness is the McBurney's, not diagnostic. Okay, but it's classical, one of the classical features of the acute appendicitis, but it is not diagnostic. Okay, not diagnostic. It may vary. Okay, because depending on the position of the appendix, the tenderness site can vary. But if it is there, it is suggestive of acute appendicitis, McBurney's point tenderness. So here it seems to be correct. What they have given is correct. Okay, it's classical sign but not diagnostic. So USG is diagnostic for children and pregnant women. Yes, in children and pregnant women, ultrasound is the investigation of choice for acute appendicitis. Ochsner-Sherin regimen is preferred treatment in appendicular mass. Absolutely right. In case of appendicular mass, we don't go ahead with surgery. We always follow a wait and watch, like observational treatment using Ochsner-Sherin regimen. Okay, and then we go for interval appendicectomy after 6 weeks. So fourth one is, after conservative management of interval appendicectomy is mandatory. No, not at all. Okay, this is a wrong option. Okay, it's not always mandatory. In case of mild appendicitis and all, we can still wait. Okay, so always appendicectomy is not a must or mandatory. If it's a severe recurrent appendicitis, then we can go ahead with the appendicectomy in case of after conservative management of acute appendicitis. Okay, so option A, B, C are right, not the D. So I think option B has got all those three options, A, B, C. So that will be the right answer. Okay. Next question on burns. They'd asked you something like hot water, hot milk spilled over the forehand. Looking at the image, what's your the degree of burns or the depth of burn injury they had asked. My students told that there are blisters were seen. If the blister were seen, it's a classical. No need to go to see the options also. It's always superficial, partial thickness burns. Okay, and even otherwise, if there were no blisters, looking at the any just history is enough. Any domestic burns, it will be superficial, partial thickness. It can't be the full thickness, eschar or deep burns. Okay, so hot milk poured over hand looks extremely red. Okay, painful blisters are present. All these are suggestive of superficial, partial thickness burns. Burns and trauma we have discussed in detail with great attention. So with lot of MCQs, practice questions. So you would have definitely got this right. I'm very sure. Okay. Burns, they'll ask mainly three types of questions. One is this degree of burns or grading of burns. Second thing will be Parkland formula. Third thing will be that rule of 9. Okay, these three are the invariably asked question, and of course the fluid management, which fluids will be used, all those things. Incorrect statement regarding stoma. Colostomy is usually flushed or averted. That's correct. Okay. Ileostomy is usually pouted, means it comes out like this. That's also correct. Okay. Temporary stomas are usually loop fashions. Correct. We can just close the loop then. Ileostomy or colostomy. Colostomies are commonly associated with fluid electrolyte imbalance. That's incorrect. Okay, because usually when it reaches the colon, it will be mainly all the fluids and electrolytes would have been absorbed. Only hard stools are formed then. So in colon, the fluid and electrolytes loss or imbalance is very less compared to the ileostomies. Okay, in ileum the chances are more. So this is the incorrect answer, the fourth one. So that will be the right answer. Incorrect statement regarding stomas. Okay, colostomy is usually just it will be just averted into the surface, whereas ileostomy, colostomy is just like this. Okay, colostomy, whereas ileostomy it will be usually coming out like this. Okay, coming out like this, because the content is such that it may peep into the surrounding skin and cause excoriations and all. So we keep it little pouted like this, pouted over the surface like this. Okay, stoma. And whereas it will be this flat colostomy. Usually we keep loop colostomy or loop ileostomy in case of temporary diversions. Then just from there only we can just close the stoma. Okay, so the fourth option is wrong. Post-op day 3 of lab coli, patient came with pain abdomen on ultrasound. USG ultrasound fluid in the right hypogastrium is seen. MRCP showed cystic duct stump leak. What is the management? It's a repeat question. Okay, there were two or three PYQs were there in the entire surgery questions. One of them is this particular question. What is the management for the cystic duct leak? They are asking. This we know this is as a bismuth type A CBD injury. For this, the treatment would be, there is a, see, this is the right left hepatic duct. This CBD was like this. We had put clips like this, and we have cut the cystic duct. So some of this was been removed after that. This gallbladder is removed. Okay, gallbladder is removed. So cystic duct was like this, cystic duct. Somehow this clip got dislodged. Say this clip got dislodged. Okay, now it's leaking from this. This is a leak, by leak. So this is bismuth type A. Okay, from right aberrant duct or from the cystic duct there is a leak. It's type A. For type A, what you need to do is just do a ERCP and stenting. Take a stent and cover this cystic duct like this. So bile will directly flow like this. It won't leak. Understood, no? So it's not exploratory laparotomy. It's not needle aspiration or conservative. ERCP and stenting will be the answer. Okay, this Bismuth-Strassburg classification is very, very important. We need to know this, all the classification and management of each. Okay, very high yielding topic. Okay, at another question on laparoscopy. This is again PYQ. Last year they had asked on this azimuth angle. This time they had asked another angle. Okay, so they have given this image something. What is the angle 1? They are asking between the two working ports. They are asking between the two working ports, what is this angle called? So between these two working ports like this. So this is nothing but the manipulation angle. Azimuth is between the camera and the one working port. Okay, this is azimuth angle. Between two working ports, it is the manipulation, and the body surface and one working port is elevation angle. So these three are the important angles in laparoscopy. So this is the camera. Okay, this is the camera and one instrument is azimuth angle. Okay, usually 30 degree. Okay, and between two working ports, okay, this is the 60 degree. It's called manipulation angle. And from the body surface to the working like this, whatever you're holding, from the body level supine to the instrument, the whatever angle, usually 30 degree, that is called elevation angle, 30 to 60 degree. Okay, elevation angle. So these are the three angles in laparoscopic ergonomics. Next question, I think there were 4 conditions were given, and which is the diagnosis, investigation of choice they had asked, I think, to match the following something, this kind of question. So again, if you look at the options, parathyroid adenoma, GRD, achalasia cardian, CA esophagus, the investigation of choice for this parathyroid adenoma, we know it's system EB scan. Okay, system EB scan. GERD, it is 24-hour pH monitoring. Achalasia cardia, because of this failure to relaxation of the lower sphincter, so pressure will be high, measured using manometry. Carcinoma esophagus, always do endoscopy or EUS guided biopsy, endoscopic ultrasound guided biopsy. Okay, these are the options. Whatever the options were there, 1, 2, 3, 4, you could have selected accordingly. Okay, all these are very important topics: GERD, achalasia cardia, carcinoma esophagus. One question will definitely invariably come from these. So, and very straightforward factual questions. I am very sure. Not much concepts involved, so you would have got definitely right. Which is not seen in late dumping. This is an interesting question, and again a PYQ. Okay, PYQ. Early dumping and late dumping. Early dumping because of the hypotension, whereas late dumping because of the hypoglycemia. Okay, so which is not seen, they have asked. So we'll see. Tremors and palpitations. Tremors and palpitations are usually seen in hypoglycemia, so that will be seen. Okay, occurs 2 hours after the meal. That's correct. Aggravated by exercise, correct. Hypoglycemia, that's correct. Relieves on lying down. Lying down will be relieved by hypertension will be relieved, but not hypoglycemia. Correct. Hypoglycemia is relieved by taking food. Correct. So this is the wrong answer. So which is not seen is relieves on lying down. Whereas early dumping will be relieved on lying down. Late dumping will be relieved on taking food. Okay. So that's about the complications of gastrectomy. They can be asked. Billroth 1, Billroth 2, on other post gastrectomy. All the complications can be a question, important one, especially dumping syndrome. It's their favorite. Patient with recurrent gastric ulcers. When you just read this only, you got the answer. Like recurrent gastric ulcer, with especially in D2. Okay, that is gastrinoma we are dealing with. Gastrinoma, okay, hypergastrinemia. Seen most commonly in this again PYQ. Last time also it was asked. Pazar's triangle. Okay, gastrinoma triangle or Pazar's triangle. What is the next step they have asked? They have not asked about the boundaries, or last time they had asked the boundary of Pazar's triangle. This time, and even in FMG question also asked same thing. This time, so they have asked what is the gastrinoma? Suspecting gastrinoma. What is the diagnostic step? What is the next step? Okay, in the diagnosis, it's of course it's not serum insulin, or we are not pheochromocytoma, so 24-hour urinary catecholamines. not primary hyperparathyroidism, but gastrinomys, serum gastrin. Simple. I don't know why they have asked this kind of questions in INICET. Very simple, straightforward. And next question, again very simple. The image based question. Patient came to emergency with head injury, 2 episodes of vomiting, and patient is stuporous. So suggestive of the increased intracranial pressure. So what is the next step in management? So you have to do the decompression. Okay, you have to do the decompression, not craniectomy. Craniectomy was option, I think. Okay, if craniotomy was the option, then it's okay. Craniectomy we do only for cerebral edema, electively. Don't do in trauma and all. In elective cases, if there is some cerebral edema and all, we do craniectomy. In trauma scenarios, we always do any bleeding inside with the mass effect and all. We always go ahead with burr hole and evacuation of the clots. Okay, craniotomy. Burr hole is a type of craniotomy only. Okay. Conservative management is ruled out. Observation no role. Craniectomy also we don't do. So answer here is burr hole craniotomy with evacuation of the clots. Okay. Okay, that's it. Then there are 2-3 other questions also. Okay, so they are having overlap with radiology, pathology, and physiology. I think respective faculties would have discussed them on Caroli's disease, one parathyroid, okay, melanoma. So many questions were there, but they are overlapping questions. So already discussed by the other faculties. So if any other doubts you are having, any more clarifications are required on these, please check the notes once. Almost all the things have been covered there in our class notes. Still, if you want any clarification, please write a mail to me at surgeonkishan@gmail.com. Okay. Thank you so much. Thank you.